the data and see quality. Then it would be great and we all the center and sharing the data in the intake of the what is called to promote because in the center because it's more in the center I switch on your data for the collecting to solve last 2 years we are not yet MVP in the public sector. But right now they already set up and the Ministry of Health already launched MVP in this national system. So all the case that coming to the NCC to the national cancer we have to register. So we will soon have a big amount of the data for the study in the next 6 years. Thank you. Next. So let's review here from Professor Kim Move, the Professor of Surgery Division of Gastrointestinal and Surgery, General Surgery at OASU Digestive Center, South Waterfront, Portland, Oregon, USA, in the topic of the OASU approach to the Synchronous Colorectal Metastases. Please welcome, Professor.
Hi, thank you for having me come here. This talk won't be as good as the last two, so you might have permission to sleep for the next 20 minutes. I'll give you an opportunity to relax. So I'm going to talk about patients who have colon cancer and stage 4 cancer where it's spread to the liver. Dr. Liana spoke about stage 2 or 3 cancer. This is stage 4. So what do we do if it's spread to the liver? I have no financial disclosures. Just I'm a human plumber, so I deal with the colon. So we're talking about the liver. I've got a lot of slides from liver surgeons. Or lots more than mine. So how do we stage colon cancer? So there are standard tests we do. We do a blood test called CEA, which is sometimes elevated. CT of the chest on impose without any contrast to see if it spreads to the liver or lungs. This is generally how ER doctors examine patients. There's also we do a full colonoscopy if it's not obstructing, and if it's obstructing, we get a colonoscopy after we remove the obstructing cancer. And then we do specialized testing for the biopsies. We basically look for mismatch repair genes, which will become relevant in terms of the type of chemotherapy they get. And then this metastatic, which is what we're talking about, we do special mutation analysis. The mutation analysis will tell you which chemotherapies are more or less effective for this metastatic cancer. In MRI, I believe what I contrast is really helpful. Sometimes you'll see lesions on CAT scan, which actually may not be metastatic disease, and there are characteristic findings on MRI that you can tell you for sure this is not metastatic disease. So rectal cancer is basically the same thing as the previous slide. It's with an MRI of the pelvis, which gives us more information on how deep the cancer or how locally advanced the cancer is. So we found colon cancer and spread to the liver. So what next? Well, it used to be really easy. You either get chemotherapy or you say, I don't want chemotherapy, I'm just going to go to Thailand and die in peace. But now we have the multidisciplinary GI oncology conference the previous doctor discussed, and basically we talk about the symptoms, the history of the exam, the staging. We'll have the radiology review the x-rays, make sure we agree with the staging. We'll have our pathologists look at the slides, make sure we agree, yes, it really is cancer. And then we talk about, are they having symptoms? Is this just found because they were a good patient and they got a screening colonoscopy, or is it they having bleeding or pain or nausea or weight loss? And then if it spreads the liver, we have a liver surgeons who attend the meeting and tell us, well, can we resect it? And part of the decision on whether or not to resect it is, if you cut out the cancer from the liver, do you have enough liver left over to survive? So this year, they actually pulled a bunch of hepatobiliary surgeons from Europe and Africa, and they said, well, how much liver do you need to survive? So the idea is that if you have totally normal liver, you can actually remove 80% of your liver. If you have 20% left, it'll go back and it'll be fine. But then if you have chemotherapy and you have a fatty liver, like my liver, because I eat too much, I need 30% of my liver to survive a liver resection. And if you're cirrhotic, so you have hepatitis C, we have alcoholic cirrhosis, or what we call MALT, metabolic associated liver disease, you need 40% of the liver to survive. So what happens if you have a primary colon cancer and a liver metastases, which is more important? So it used to be pretty easy. Since I'm a colorectal surgeon, of course the colon is more important, right? You just take care of the colon and I'll let someone else figure out the rest. But we know that if you don't have symptoms, it really doesn't help. So if you get symptoms, so they can't eat, they're distended, they're obstructed, they have nausea, vomiting, then we're going to cut out the cancer. So we relieve the obstruction, or we can divert the cancer, so proximal bowel before the cancer, and make an ostomy, or we can have a stent, which I'll show you a picture of at the end of the talk. Or you can just do chemotherapy. Chemotherapy is clearly the most important person, or the most important treatment in patients who've had the cancer spread. So we know that if you don't treat metastatic disease, your life expectancy is like 6 to 9 months. But if you get chemotherapy, you can almost live 2 years and live a better quality of life. So apparently I'm not so important in the treatment of colorectal cancer that's spread. So our liver lesions resectable, and this is where the radiologist will look at the MRI, and the liver surgeon will look at it and say, hey, can we remove it? They say, oh yeah, there's just a couple of things we can just cut out. Then I can actually cut out the colon, and then you can cut out the liver, and they can have up to 60%, 5-year survival, which is pretty good for metastatic cancer. And of course, it's all by chemotherapy. But of course, there are two recent trials, recent being last year, which shows that if you have no symptoms, so cancer isn't bothering you, and spread, that you have no benefit from having surgery. You just have the risks of the surgery and complications and all that. So for our institution, we start with chemotherapy. So what if the liver lesions can't come out? There's just too much of it. It's just too many of them. We can't cut them out. The options are chemotherapy, standard chemotherapy, which we'll talk about a little bit later. Is something that's kind of sexy and really expensive. So it's called hepatic artery infusion. So it's where first for $25, which is significantly cheaper than Prada, which I don't normally buy. So FUDR is when you take so 5 years is when you take the fake Prada purse, you put it in a nice box, you give it to your wife. She opens it, realizes it's fake, hits me over the head. That's 5 years so. FUDR is where you don't put it in the box, you just give it to your wife, and she hits you faster. Both of which involves you getting hit. But that's what we use for chemotherapy for the liver metastases. Man, this is what me with my wife. Okay. Okay, so I'll just do it this way. We gotta do it that way. Okay, so the idea for using a pump. So here's the pump that we do, and it's like underneath the skin, and it goes into the artery right here. And this artery goes straight to the liver. And most of the blood supply to the metastases in the liver are fed by the hepatic artery. So if you get the chemotherapy through here, it goes straight to the liver metastases, and it treats that, and then the liver basically destroys the rest, and it doesn't affect the rest of the body. So it's actually really nice. Of the people who have metastatic disease, about half of them will have liver disease, and sometimes the liver is the only place that has it. So what are the advantages? It has an increased response rate. And why does it have an increased response rate? It's because when you give the fake purse, Novox, to your wife, it gets concentrated in the liver up to 400 times the level you could give if you just give IV chemotherapy. So 400 times more. It's like a way better deal, right? 400 times more than what you normally get if you just put in the vein is if you put it directly into the liver. And then you have a chance to convert it to potentially treating so much of the disease. You can actually do surgery because the lesions are smaller or they're fewer, so you can actually cut them out. And then we actually have studies that suggest that you are more likely to live, or you'll live longer if you do this. So what are the contraindications? The thing is, the pump only goes into the artery that goes to the liver, so it only treats the liver. So if it only treats the liver and you have spread of cancer outside the liver, then it's not very good. So a big reason, some reason why you can't use it is because it spreads to the peritoneum. Like in the previous talk, where the gastric cancer spread to the peritoneum or other organs. If the artery actually doesn't go to the liver, so the artery you think that you're putting it in doesn't actually go to the liver, it goes into some other location. If you have a biliary stricture, because one complication of the artery is when you put chemotherapy in the liver, it can actually cause scarring of the bile ducts. So let's skip this and then we choose time. Let's skip that and we choose time. So basically, my favorite study is this one, Kemeny. She is a surgeon, a liver surgeon out of Memorial Sloan Kettering in New York City, and she placed a lot of pumps, actually in the 1980s and 1990s, and she used the FUDR. That's where you have the Protoburst, Novox, give it to your wife, and then she had over half of them actually go from unresectable, where you can't cut them out, to resectable. And then let's skip to here. These are some live pictures where you can see the catheter going into the artery, and this artery goes into the liver. And then to make sure that this actually works, they put fluorescein into the pump intra-op, and they inject it, and you can see both sides of the liver lights up nice and pretty green. That means that if you give the chemotherapy, it'll fill up the whole liver. This is, you don't want it to go through only just half the liver and not treat the other side. So we do that, and those look really pretty. It's like at the band concerts where you wave the thing because you're happy about the music. Okay, so this is an actual, let's look at this trial. So this is a prospective trial where we compared, so that patients with colon cancer, it's spread to the liver, you can't cut it out, you can't cure them. So we're comparing, we're looking at people who had the pump, and they're also getting other chemotherapy, and then looking at if you get to a point where you can actually cut everything out for a year, that your survival looks like this. But if you don't respond, then it looks like this. So they were projecting that that these patients would die within 20 months. Okay, but their survival was about 46 months. So just chemotherapy alone for metastases is between 20, 22, maybe 24 months. But if you add the pump, they live almost twice as long. So how we approach a patient with spread to the liver. So this is kind of getting into, so how do we do it? So we start with staging with a CT scan of the chest, island, and pelvis to see, is there anything in the liver, is there anything in the lungs? And there's some spots in the liver, we can MRI the abdomen with pelvis. Because our radiologists are actually so good, as good, almost as good as yours, where they can actually look at the MRI and say, yep, definitely not cancer. So you can save the patient, a biopsy where they get stabbed into the right quadrant. But if the MRI really says, yeah, that really looks terrible, we might get biopsy. So why do we get biopsy? We say, yep, that's not from cancer, it's spread. Why don't you just do chemotherapy? It's because if we get the tissue from the liver, and we do mutational analysis, we can figure out which chemotherapy drugs will actually work. You don't want to give them the wrong chemotherapy drugs, and this is true of most things, you want to do it right the first time. So if you have some mutation, we'll respond to this medication, but if it's this mutation, we'll respond to a different medication. And then I'll show you a picture of a CT angiogram where it's basically CT angiogram to look at the vessels that go into the liver to see, yep, there's an artery that we would put it in actually go to the liver. And then we discuss it at that multidisciplinary conference and say, hey, does everyone agree that the pump is the right thing, or should we just do chemotherapy? Because sometimes the pump isn't the right thing. For example, if a patient is very rural and they can't follow up every 2 months for infusions, then the pump isn't the right thing. And they also, if the pump runs dry, like it's empty, then basically the whole thing will clog off, and then it'll be a big problem. Then we do 4 cycles of systemic chemotherapy. So we give FOLFOX. And then we restage with all the CT chest and pelvis, the MRI, the abdomen, and then if they decide it's resectable, okay, and it requires a major hepatectomy. So what's a major hepatectomy? A major hepatectomy is when you cut out half the liver. That's big. So if you think they can get it all and requires you kind of have the liver, they don't want to add a colon surgery. Because us plumbers, we can just screw things up and cause complications like wound infections, anastomotic leaks, post-op pneumonia. That's actually mostly just me. I would say that they just want to do liver resection, more chemotherapy, and then they let me finally operate on the patient. If it's unresectable, that's when we do the resection of the primary cancer in the colon and then replace the pump. So why do we do that? Because the pump only sends chemotherapy to the liver. Since it only sends it to the liver, the cancer in the colon is untreated. So if it's untreated, you don't want to treat half the disease. But if you cut out the colon that has the cancer, then the only thing you're treating is the disease that's left. And that's the idea. So we tend to do what we call synchronous resections. And so, like last week, we actually did 3 of these combined surgeries where we removed the colon or rectum and placed a pump on Monday, Tuesday, Wednesday with 3 different liver surgeons, 3 different colon surgeons, which I was one of them. So this is some of the data that has been shown that basically if you remove the bit of the colon plus the pump, or you just place the pump, it doesn't change the number of people who can start the chemotherapy, the time of chemotherapy. We actually did a little bit of extra chemotherapy on the side to try to help things along in case we missed anything. But over time, so basically, it's not a bad idea. To be honest, most of ours are baby colectomies, not real colectomies. So we do a right colectomy, a left colectomy, left sigmoid colectomy, which isn't a big deal. It's like when you're waking up, and you continue in the morning. It's super easy. I can do it half asleep. Like I have. And then the rectal surgeries, though, that's a big deal, and that has a higher risk for complication and bleeding. And those we are really more nervous about doing it. But we've done it successfully with a pretty low complication rate. So we have a bunch of liver surgeons, a bunch of colorectal surgeons, and we've all done this. And then the complication rate is actually, we haven't had anyone die good. We've had minor complications. Like we had a couple of people go to ICU. We had a couple of people go to ICU and require multiple organs being supported, but we haven't had any major problems. So it doesn't affect the length of stay, how long they're in the hospital, even though it's an additional big surgery. So this is what's exciting. So in the past, so this is a new trial that we're actually recruiting for. So in the past, what we do is, okay, we do the staging, we do a multidisciplinary conference, we decide, yep, what we want to do is place a pump and cut the other thing, the colon surgery at the same time. But then it doesn't change anything about the pump or the colon surgery. And it says, what other chemotherapy are you adding besides the pump? So traditionally, we just use the 5FU. The 5FU is a product, fake product, inbox, give it to your wife, get whacked. So, but simply about saying, well, what do we do real chemotherapy and add Folfox, which adds our oxaliplatin. So people are being randomized to whether they get the pump plus the pump chemotherapy plus extra chemotherapy, or the industry standard or the institutional standard to see if maybe if you had real chemotherapy in addition to the pump, that they'd do better. So we don't have any data for this because we're still recruiting patients. In fact, I just did a patient last week. So this is our sample patient. So our sample patient is DL. She's 49. So actually, normally the average age of colon cancer used to be 60. The mean age used to be 60. But in the last few months, all of operating are below the age of 50. So I don't know why people are having early onset colorectal cancer, but they're really young. So she presents with a 30-pound weight loss, which is a lot. If I lost 30 pounds, I'd actually look better. But then upper abdominal pain. So pain, weight loss. That's a lot of weight loss. That's a lot of pain. So the work eventually found a adenocarcinoma in the rectal sigmoid, just at the top of the rectum, and liver metastases on both sides. So you can't cut out the right and left liver because that means you remove the whole liver and then they die. So they did a biopsy of the liver mass. So the MRI confirmed that it looked like there was a liver metastasis. They used ultrasound, they biopsied the liver mass. It's adenocarcinoma, so it looks like it's spread from the colon. And the immunohistochemistry looking for funny missing proteins through the ultrasound. So they did gene trails, and basically they look at microsatellite stability, which basically says it's not really going to benefit from immunotherapy. most of the things are pretty benign. So you can pretty much give any chemotherapy you want. So she started chemotherapy. So FOLFOX stands for folic acid or leucovorin. The F stands for the 5-FU, which is the fake purse in box, and then oxaliplatin, which actually cross-links the DNA. She had a bunch of cycles, and she had panitumumab. Panitumumab actually is monoclonal antibody against epidermal growth factor. So the colon lining is actually epidermis. So if you prevent the epidermis from growing, you can help the colon cancer from being bigger. So she started getting that. And then she comes to my office. Actually, that's my emergency room. So she has a large bowel obstruction because the cancer basically, it's on the inside of the colon and basically so big that she couldn't poo. And then she backed up and she started throwing up and she's completely obstructed. So I had to figure out, what are we going to do? So this is a CT scan that shows her. So this is basically a tumor almost replacing the right lobe of the liver. So the liver should look like this nice white, but all that black is cancer. And there's more black on the left side of the liver. And pretty much, it looks like she's 90% cancer and 10% liver. So you can't cut all this out and be compatible with life. And then she also has a cancer right here. So this is S1, S2, S3. In the upper pelvis is this cancer causing the blockage. And this big thing right here, that's the obstructed colon before the blockage. So it's a big problem. And that's what I specialize in, big problems at inconvenient times, which is typically 5 p.m. on Friday. So luckily, I am friends with my GI colleagues. They saw this patient. So you can see this. So this is a cancer right here, and this that tiny black dot that is the only space that you can get through. And they stuck a stent in there and blown it up to open it up. And then she was able to pull again, which is great. So that means it wasn't my problem. And then we got an MRI of the pelvis, and it was actually 12.6 centimeters from the anus, which is actually pretty high. It's rectal, but it's not really rectal. It's like at the very top. And then it's at T3B, so it's what Dr. Juliana described as locally advanced, as neural positive. So both are reasons they have like total neoadjuvant therapy, but because it wasn't rectal, you think about radiation, we're just thinking about chemotherapy. So this is the MRI, and the MRI. So imagine it's hard with the lighting, but this is the tumor right here. And this thing right here is the top of the stent, and this is the bottom of the stent, and this is the bladder. So this is the MRI we just talked about, just pictures. So this is so what they do is when they do a CT angiogram, they give IV contrast, do a CAT scan with tons of X-rays, and they reconstruct it. So this is the aorta right here. This is the celiac axis. This is splenic artery. This is the common hepatic. Most surgeons can just jump in there. This is the gastroduodenal. This is the thing that we basically cut in half and stick the artery on, the pump into the artery so it can go to the liver. So this is actually standard. I don't have it, but I would do this, but on my desktop, I can actually take this image and turn it around like a carousel. So you can look at it from like the front and back and sides. So yep, the anatomy is normal, could be a candidate for a hepatic artery pump. So I presented it to the tumor board, and they agreed. When they looked at the first CAT scan, yep, totally unresectable. It was completely replaced by cancer, but she may be a candidate for this hepatic artery infusion pump. So to be a candidate, you need at least 6 cycles of chemotherapy, and then you need to restage to see if, yep, it's still unresectable. So we have to do something, which is either do chemotherapy, do nothing, or do a pump. And so because she's only had 3 cycles before she met me with the blockage, she needed 3 more cycles to be considered for the trial. So she got 3 more cycles. So now she got 6 cycles, and we repeated the x-rays, and yep, they're the exact same thing. It was bad cancer, replacing most of the liver. It was slightly less bad, it's still horrible. So doing the surgery roughly 3 weeks ago now, we started with diagnostic laparoscopy. Why do we do that? We want to look to see that there's no disease outside the liver. So we know this disease in the colon, the disease in the liver. We want to make sure it's not anywhere else that would preclude us from placing a pump. And then the liver surgeon placed the pump. They did other things I don't understand. Got the gallbladder because it's a buy one get one free kind of thing. and then, which isn't actually true. And then Dr. Selena was actually a telesurgeon from BDMS. She actually went and watched the surgery. And then she saw this elegant liver surgery and the placement of the pump. And then I started, and then she left. She's too polite to start screaming and swearing and tied. So I did open arterial resection. The left ovary stuck, so the arm blocks something the oophorectomy. I got the bleeding, which is why I'm glad she left. And then it turns out that if you place a stent, it doesn't leave the obstruction, but there's a lot of inflammation around it, so it made the surgery really treacherous and difficult. So I kind of wish I did a diverting acid instead. So nccn.org is a really nice website that you can actually get on for free. They recently updated for this year recommendations for colon cancer and rectal cancer. And everything I've described is actually on that website, except for more colorful references to the market. So anyway, thank you for the time and listening to me, and you guys can now wake up in the next excellent talk. Thank you very much, Professor Wu, for your wonderful presentation. Is there any question from the audience? Okay, thanks for the opportunity.
I have some questions.
Okay.
In terms of question, so there will be a question from someone who is outside of the field. So I'm a immunologist. And so I would like to kind of know, you say that you would give chemotherapy first or patient who have colorectal cancer with liver metastases, and then you restage, right? If it's unresectable, you will place the hepatic artery infusion arm and then get the primary section resected out. The second patient who when get the chemotherapy with the pump and then the lesions become resectable after that, and what would you will
So I would say that about what they found is with hepatic artery infusion pumps, about 50 to 55% of them go from unresectable to resectable. And then the decision about what to resect is really falls in the court of the liver surgeon. So if they have to do a major resection, even though it's all resectable, they typically don't like us to do a colectomy at the same time. Because if we cut out the colon and we put them back together again, which is what the patient wants, because they don't want an ostomy, and it leaks, then the stress of the last liver, possible liver failure, and then sepsis is a bad combination. With a patient, we did a major hepatectomy on, and just a right colectomy, which is a small surgery, and they had a major problem with ICU for months. So generally speaking for us, if it's like a more minor thing where they can, for example, wedge out or cut out a little bit of like a bunch of lesions and they can microwave ablation something else, so there's a lot of liver left and it's not a major resection, then we'll do that.
To add to that, Dr. Mayo. Dr. Mayo was also going to say you have stable long head visual basis. When we have focused for an HI problem, it's because we cannot resect them. And we resected colon because they're not going to receive any treatment for the fall. They're not receiving colon, it's step therapy. So this is why we've always pushed very hard when they get a big chat for 70 million vaccines, the primary needs to be received. Now, Dr. Mayo has published the data for not just you, 40% of those patients went surgery for a month. However, there's a lot of interest for patients that response to HIs that are symptomatic, but they are transplant candidates. Although we don't do liver transplant, we will direct liver metastasis. It's not the way it's very bad. And a center, there are surgeons that they consider solutions. So even when we have pushed the envelope now, 100% of the liver mets to get them to the point, not only you took care of primary, and you have minimized disease to get them to a section or to give them an opportunity.
In terms of liver transplant, one of the criteria is that the lesion has no lesion can be more than 10 centimeters. And the second thing is it can have no extra liver or extrahepatic liver disease. Because the idea is if all the problem is in the liver and you remove the entire liver and it's a transplant, there's no cancer left. So it feels safe about doing a transplant. We actually don't do that, but the thing is, she would never qualify for a transplant because her after 6 cycles, her CAT scan looks pretty similar, and that's clearly more than 10 centimeters. So she just wouldn't qualify. And she's actually pretty young. She's 49 and otherwise healthy. So for her, doing resection and the pump was a good option. So of all the places who don't have access to liver surgeons with this specialty, because it takes a lot of expertise to do this, so they would just get chemotherapy, which is also acceptable too. It's just that we know that patients who do qualify for the pump, they tend to do better than people who just get chemotherapy.
Thank you for beautiful discussion today. As a young generation session, today I'm also learning from the exercise of both of you, and you can learn something small news, and I just sharing some practice of my daily practice because it can be advantage of time. Some of the case, my case can come in the midnight with a power obstruction, for example, the intellectual sigmoid with metastases. And for sure, as you said, we have to reset the primary too. Also, we can see like cancer with a nose like no adjuvant therapy in the midnight power obstruction is we can carry this patient can be setting the tumor at the same time with ostomy and it would be able to research the metastases like lobectomy or segmentectomy of the metastases of the liver. The patient in this country that for to prolong the survival rate of as many cases of my case that I did a study comparing about the some surgeon that they just only receive primary tumor and they keep the second like the metastasis and the liver. That's the survival rate is not so different. And yes, and today it's really impressive for discussing about this point. But the major liver resection like you research the primary tumor, they have a right metastasis at the right lobe of the liver and needs to a major liver resection. For sure, should be do at the same time because first it's really complex. It prolongs the operation time, and if we are not yet ready for a major resection, so the patient can have like liver failure or liver insufficiency after hepatectomy also.
I mean, according to the guidelines, you can actually resect the primary if you have a bleeding or obstruction, and do a limited resection of the liver if it's just a couple things. So that's totally acceptable when you follow with chemotherapy. But if you have a major resection, it's hard to do a major liver resection at 2 a.m. So I think that even do it to radiolostomy, just to bypass the blockage, that's a small operation will help relieve the obstruction. And that way you don't have to dig out a stuck rectosigmoid cancer off the left retroperitoneum in the middle of the night. And that's an option too. Any other questions? I have a powder purse if you want to buy it back for $25 because I have to buy a real one now. So.
So, show for this release.